All right, so hi everyone. For those of you who I haven't met, I'm Yoviene Sykes. I'm a clinical psychologist at the STEP program, and I'm also the director of the STEP Learning Collaborative. And in addition to those professional roles, I also identify as a family member of someone with schizophrenia. I'm really excited to welcome you all to the STEP Learning Collaborative training series. These trainings are intended for frontline clinicians of various disciplines working to support individuals and families impacted by early psychosis. And so although that's our target audience for this series, this is also open to interested community members and family members looking to learn a little bit more about early psychosis. The focus of today's talk is on early identification, and we'll really work on just trying to level set with some background on early psychosis, thinking about common differentials, signs, risk factors, as well as some assessment tools and strategies. Future training sessions will dive more into in-depth strategies for various treatment approaches. So we'll go through all of that for the bulk of today's training, and then we'll also share with you the updates from the STEP Learning Collaborative and the Mind Map Early Detection campaign to let you all know, if you don't know already, about our new centralized referral number and our network of providers across the state. And we'll also detail some of the upcoming offerings that are available both for providers as well as for community and family members. So let's dive in. What is psychosis? So when I talk about psychosis, I'm not referring to a specific diagnosis. Rather, it's an umbrella term that describes a medical syndrome that can be diagnosed based on a cluster of characteristic changes in thinking, feeling, and behavior. During an episode of psychosis, individuals can struggle to differentiate what's real from what's not real, and may come to believe false explanations for their experiences. Psychosis is more common than many folks might think. Every 3 in 100 people will experience psychosis at some point during their lifetime, and about 1 in 100 will develop a schizophrenia spectrum disorder. Psychosis doesn't discriminate. It can impact any race, gender, sexual orientation, religion, socioeconomic status. Psychotic disorders typically emerge during late adolescence and early adulthood and have a lifetime prevalence of about 3%, as I mentioned. Psychosis can often lead to, especially if it's untreated, frequent hospitalization. It can really, unfortunately, derail functioning in school, career, and social relationships at a critical juncture of a young person's life. However, there's accumulating evidence that early identification and intervention can minimize the potential disability that can be caused by these disorders and truly improve lives and help folks get back on track, which I'll talk more about. The peak incidence is about 21 years of age, a little bit earlier usually for males than those females. And when I talk about first episode psychosis, this is simply referring to the first time that someone experiences psychotic symptoms or a psychotic episode. People experiencing a first episode of psychosis might not understand what is happening. The symptoms can be highly disturbing and unfamiliar, can leave the person feeling confused and distressed, and family members or loved ones may also just feel kind of confused or bewildered about what is going on. At the STEP Learning Collaborative and at the STEP Clinic in New Haven, we focus on the first 3 years since onset of full psychotic symptoms. So that's how we define first episode, although there's some variation across the literature and across clinics. And again, when I'm thinking about first episode, it's a first episode of something. It's very common. This is important to recognize that there's a lot of diagnostic ambiguity or uncertainty, and that is an expected part of early psychosis treatment, as there are many different causes of psychosis, which I'll talk about shortly. Although for the sake of the STEP Learning Collaborative and for these talks, we're truly looking to identify what will end up being first episode schizophrenia. Ultimately, in the state of Connecticut, we estimate that there are approximately 500 new cases of schizophrenia each year, and then 3 times that number will experience symptoms of psychosis, but won't necessarily experience a more chronic schizophrenia spectrum disorder. What are the common causes of psychosis? Psychosis can have several causes, and careful assessment is required to distinguish between episodes that are caused by a variety of medical illnesses, such as Parkinson's, epilepsy, infections, or drug-induced psychoses that might be caused by cocaine, stimulants, cannabis. Once these other causes are considered and likely ruled out, the most likely reason for psychosis in a young adult is the emergence of a schizophrenia spectrum disorder or other mental illness that has affective components, such as a bipolar disorder or a depression. Diving in a little, but if someone is presenting to you experiencing symptoms of psychosis or psychotic-like symptoms, you can go through these kind of questions to guide your differential. And again, recognizing that there can be a lot of ambiguity, especially early in this course. We just kind of put here a reference slide. So questions to guide you. One of the first questions you might want to rule out is, okay, this person's presenting with some symptoms of psychosis, perhaps some what seems like delusional thinking or auditory hallucinations. My first question is, can this be better explained by a medical illness or acute substance use? If no, I rule that out. Then I want to think, okay, are there prominent mood symptoms? Is there a manic episode going on or a major depressive episode going on? And is that explaining or fully accounting for the symptoms of psychosis? Are the symptoms of psychosis completely contained in a mood episode, or do they also happen outside of a manic episode or outside of a depression, even if both things are happening? So other questions to ask yourself, just to go through some common differentials. Although again, I don't know that landing on the kind of perfect diagnosis is exactly what we need to do here, but wanted to kind of provide this for everyone to be able to reference throughout their care as they kind of continue to update their working hypothesis and working formulation, what might be going on for a young person. Want to check out if there's a delusional disorder going on. You can certainly be guided by the duration of the symptoms only occurring very briefly for less than a month, and then do they subside on their own without treatment? You might have a brief psychotic disorder. If they're really, really early in the course, between 1 and 6 months, you have a schizophreniform. And if we're greater than 6 months of kind of sustained symptoms, we'd likely classify that as a schizophrenia. And then, of course, there's a lot of other things to consider. People are complex. These categories of the DSM and the ICD are not perfect. People have a lot of different experiences and no two people look exactly the same. So other things that you might want to consider is, are these symptoms lower threshold? Have they not reached the level of a full psychotic symptom, which I'll help talk about later to help everyone learn how to differentiate. So might they be a prodromal symptom or considered a clinical high risk state? And might I want to get a specialized assessment for that? Are there other mental health issues going on that are better accounting for this, like a personality disorder or OCD? So a lot of different things to consider. Hopefully this guide and then this subsequent flow chart might be helpful for clinicians to be able to, again, guide their care and guide their thinking through common differentials. We've talked about kind of a bit of the overview, what causes it, how do we think about it, but what actually are the signs and symptoms of psychosis? So perhaps the symptoms that are the most recognizable set of symptoms are called positive symptoms. And when I say these, it's not positive meaning good, but think about it as positive meaning in addition to or a distortion of an individual's typical experience. So positive symptoms might involve experiences such as hallucinations or delusions. And so when I say hallucinations, this can involve any of the sensory modalities. Usually it's involving hearing or seeing, but sometimes it could be tasting, smelling, or feeling things that aren't there. So this could include things like voices, whispers, visions, different smells. Anything that could be a kind of aberration of one's sensory experience could kind of fall within this hallucination category. Another very common and recognizable symptom of psychosis would be delusions. And delusions take many forms, right? These are what we would call kind of fixed false beliefs, and they often include believing things that aren't true or are unrealistic and may even be impossible. So this can really range from something that's bizarre and implausible, such as, I'm certain there's an alien implant in my brain, or that my parents have been switched with clones, to more kind of non-bizarre, very possible beliefs, such as, my partner is cheating on me and I'm convinced of it. It's important to recognize that an inherent part of psychosis is that many folks will have what we call limited insight, meaning a lack of awareness that they are experiencing things that others don't believe are real, or that they have some impairment in their functioning. And this can be particularly challenging for family members and providers alike, but it is an expected part of kind of what's what's going on with someone, and we can work really hard to kind of help improve insight for those that are impacted, and also help come to a shared understanding of what's going on, how to explain these symptoms and experiences. So another set of symptoms commonly seen in psychosis is called negative symptoms. And so contrary to positive symptoms like hallucinations or delusions, these symptoms show a reduction in or a loss in normal perception, behavior, or functioning. So this might include things like decreased motivation, energy, less enjoyment, less interest or involvement in life at home or outside of the home. And so this might manifest as maybe some difficulty in schoolwork or job functioning, maybe paying less attention to personal appearance or hygiene. And these symptoms can be tricky to differentiate because a lot of times they can look a lot like depression, or negative symptoms can be secondary to positive symptoms, meaning someone might be withdrawing from their friends because they're actually experiencing a lot of paranoia and suspiciousness about folks, and they don't feel safe hanging out with the people that they used to or going to school. So they withdraw from home, and it appears to be kind of like a secondary negative symptom. Another set of experiences that is common in schizophrenia would be cognitive symptoms. So not everyone experiences these, and I should have said that. This is the kind of full array of different types of symptom sets, but cognitive symptoms and impacts that we can see in folks experiencing schizophrenia might include a decline in executive functioning, particularly in areas of processing speed and working memory. Folks might also experience what we kind of call thought blocking, or might have like latency in their responses. There might also be impacts in their ability to kind of complete abstract tasks or abstraction ability. And lastly, even if there's not a primary affective or mood piece going on, we actually do expect to see some mood fluctuations and anxiety, potential experiences of low mood or depression. And I'll talk about a bit more later, but also an increase in potential suicidal ideation for folks experiencing early schizophrenia. So I want to talk a bit now about the course of schizophrenia. And I hope you recognize here that I kind of shift a little bit. I mean, I will say psychosis a lot in schizophrenia, but now I'm really talking about a kind of collection of symptoms, kind of making up schizophrenia spectrum disorders. Although schizophrenia is heterogeneous, so no two people will have the exact same experience, this slide does its best to represent a typical course. On the x-axis here, we've got age, and on the y-axis here, we've got level of functioning. Most people who go on to develop schizophrenia are functioning normally or typically when they're young. So that's what we see here in this green pre-morbid box. And then really around adolescence, something begins to change. And it might look a little different for everyone, but folks might start to experience what looks like depression, there might be some trouble concentrating. We might even start to see some subclinical or attenuated psychotic-like symptoms. And so that might look like things like, instead of hearing full-form voices, maybe we start to hear noises that we're recognizing aren't real, but they are starting to increase in how much they're occurring. They're starting to gather our attention a little bit more, be bothersome. We might start to feel a little bit suspicious or paranoid about people we've typically trusted. Folks might develop some difficulty speaking clearly, but throughout all of these kind of symptoms, they might ebb and flow, and at no point does the person kind of lose insight, or do they become kind of full-fledged symptoms of psychosis. So this is the period that's known as the prodrome period on this beige box, or we'll also refer to it as clinical high-risk state. So yeah, prodrome, it has a lot of different terms. We've got prodrome, clinical high risk, ultra high risk. They're all referring to a pre-psychotic phase of illness. And you can think of these as maybe early warning signs and symptoms before the full illness onset. And there seem to be the first noticeable behavior changes or symptoms. And this is often a 1 to 3 year period before the first episode of psychosis. If we're continuing on the course of someone who goes on to develop schizophrenia, so we've got this prodrome period, you see maybe there's a decline of functioning that's starting to happen. And then right here where the beige meets the red would be our first episode of psychosis. And this will be when someone's symptoms change from kind of just annoying, frustrating, attention-catching to really convincing. Those whispers turn to maybe full-form voices, or that general suspiciousness turns to a full kind of paranoid delusion and a fully formed kind of thought where someone is completely convinced that someone might be following them, or these experiences that were low level before now feel very intense and they feel very, very real, and it's hard to convince the person otherwise. And so at this point, we might see a more dramatic drop in functioning, and this is where we often might see a first psychiatric hospitalization for an individual. This is the period that we're really kind of thinking about throughout this series of kind of this first episode of psychosis or first episode of schizophrenia, and how we can better understand and support these young people and their families. And so folks, after that first episode, with treatment, most recover, and recovery is actually the expectation when we have early intervention and treatment. But many studies kind of suggest that, folks will kind of have some decrease in their functioning. But again, one of the biggest predictors of recovery and positive long-term outcomes in psychosis is getting to treatment as quickly as possible and having a short duration of untreated psychosis. And it's important to mention that folks, a schizophrenia diagnosis, despite the stigma and things that are out there in the media and the internet, as I mentioned, recovery should be the expectation. It absolutely is possible with treatment, and folks can go on to live very fulfilling and meaningful lives, whatever that might mean for them, ranging from being doctors, having families, being advocates, whatever recovery means shouldn't be kind of off the table. And I think it's important that as providers of individuals experiencing first episode psychosis, that we hold hope for these individuals, especially if they're struggling to hold that hope for themselves, or if their families kind of are feeling scared or overwhelmed or also struggling to hold that hope. It's important that, because we know that people can improve, can respond well to treatment, and can recover important areas of their lives. So what contributes to the development of psychosis? Why does this happen? I wish there was a simple answer, but it's complex. There's no single factor that has been identified to cause psychosis. Rather, a number of factors that interact to contribute to the development of psychosis. And so we often think about the development of psychosis with a stress vulnerability illness model. It's the notion that individuals have some type of genetic or early predisposition for developing psychosis that interacts with environmental stress factors to bring about the experience of psychosis. There have been many identified risk factors that are, outlined here in this table, and I'm just going to highlight a few, which is in no way, comprehensive. But an early risk factor, that genetic piece that I was talking about, is a family history of psychotic illness. So if one has a first-degree relative with a schizophrenia spectrum disorder, you're 6 to 13 times more likely to develop a psychotic disorder. Early experiences of trauma is also a risk factor. 34% of people with early psychosis report having experienced childhood sexual or physical abuse, and PTSD rates are 10 times higher in folks with psychosis than the general population. Certainly, early trauma is a risk factor, but that in no way means that all folks who go on to experience schizophrenia had experienced an early childhood trauma. And it also doesn't mean that just because you experienced trauma in childhood that you're destined to go on to develop a psychotic disorder. Additional factors occurring kind of in later childhood or adolescence. A big one I want to highlight, especially with the kind of increase in use and legalization and access, is adolescent cannabis exposure. Adolescent cannabis exposure makes someone 2 to 4 times more likely to develop a schizophrenia spectrum disorder. The risk is greatest if the cannabis was used for a greater frequency, for a longer duration, and earlier first use. So, for example, starting at 12 puts you at higher risk than starting at 19. Also, higher potency cannabis, so higher potency THC, have kind of greater risk. And for folks who are interested in, understanding more about this, we'll have a great talk in the training series coming up in a couple months by Dr. Cyril D'Souza, who's a real expert in studying the impact of cannabis and psychosis. So I encourage you all to attend that training in the future. Additionally, experiences of migration or immigration. Folks are at 2 to 4 times increased risk if they have a childhood migration history. This is particularly true of folks who have kind of a minority status and those who have kind of experienced discrimination or other potential hardship during this process of immigration and acculturation. Why is treating psychosis important? For so many reasons. Individual and family impact. As I mentioned, psychosis can often lead to frequent hospitalizations and kind of derail functioning for a young person in general, but also at such a critical juncture, right when they're kind of about to launch from adolescence to kind of young adulthood, can impact school, career, family relationships. Unfortunately, we know that there's an increased risk of suicide. Approximately 1 in 100 people experiencing first episode psychosis will die by suicide, and as many as 10% of those individuals will attempt suicide within the first 5 years. So we really think for various reasons, but these first 5 years, the early parts of the illness after psychosis onset is what we call the critical period. And it's a time characterized by a lot of risk, but it's also the time where we tend to see the most decline in impact and functioning. However, as I'll talk about, it's also the time where intervention is the most beneficial, and we can really kind of stop or thwart kind of some of that decline in that risk by helping people get to treatment as quickly as possible. And so as if, that's not enough impact on the individual, we certainly know that families, even right, ones that are there, they're supportive, well-intentioned, that supporting someone with psychosis can have a burden, can be very challenging, both time off work if the parents are working, financial burden, emotional burden. And so it's important that we're supporting individuals and their families. And I think, probably everyone in this room, that's enough reason to motivate and understand the importance of treating schizophrenia early. But if we zoom out a little bit, this also has a large societal and economic impact. Schizophrenia is a top 10 leading cause of disability. Folks that are untreated might have kind of unnecessary criminal justice involvement that, if provided access to appropriate care sooner, those instances could be thwarted. There's an increased risk of homelessness, as well as just lost earnings from disability. But as I mentioned, right, holding on to that hope that we know this is important, and we also know that getting people to treatment quickly works and can greatly minimize these impacts and the potential disability that this illness might have on folks. So a bit more about risk. I already shared some of the risk of suicide, and just highlighting that in schizophrenia as a whole, nearly 50% of all the suicides that do occur happen within that first 5 years. And I think actually 2/3 occur within the first 6 years. So just, again, I'm going to keep repeating this. I think everyone's on board, but all the more reason that we're working so hard to detect these signs and symptoms in ourselves and in people that we care about and in our clients as early as possible to kind of help support them. There's also an increased risk of violence. There is an increased risk of violence in folks with schizophrenia above and beyond the typical population. However, that's so over dramatized and stigmatized. And I'm here to say that the majority of people with schizophrenia are not violent. In fact, folks are actually more at risk to be victims of a violent crime than to be arrested for one. And what we do know about the risk for violence and aggression in schizophrenia is that it's highest for those who are not in treatment or receiving inadequate treatment and who have comorbid substance use disorders. Additionally, supporting these folks is very important given the risk of neglect and victimization that those might experience. We've talked about kind of an overview of those different symptom domains. I'm going to zoom in a little bit and take a look at some examples of what these symptoms might actually look like. But before I do that, just want to remind you that symptoms and experiences of psychosis occur on a spectrum. Okay, so we've kind of got 3 phases of this spectrum. We've kind of got normal or typical development. We've got kind of clinical high risk or attenuated symptoms of psychosis. And then we've got full-on symptoms of psychosis that are characterized by, more complete conviction in their beliefs, impact on functioning, and other ways that, in a lot of distress associated with it potentially. Keep in mind that all of these things occur on a spectrum, and an individual might kind of ebb and flow where they're at on that spectrum throughout the course of their illness and throughout treatment. But taking a look at some common positive symptoms, and I'm going to start kind of on the lower end of that spectrum and work my way up to a more kind of psychotic level of experience. A general feeling, someone might say, lately, I've been having a hard time telling what was in my dream and what was real. So this might be in the prodromal range, depending on how often this is occurring and how much it might be impacting someone. We also see impacts of kind of disorganized communication. So this might initially look like everything has started to sound too loud and too close. It's like I can hear everything at once. And so if this is a kind of a new experience, this might be a potential sign of an emerging psychotic disorder. We know that in psychosis, there's kind of the sensory gating theory, and that typically our brains do a good job of kind of sorting out information that we want to attend to in the environment. But when an emerging psychotic disorder starts to develop, basically the floodgates open, and it's really hard to filter out what's important, or salient in our environment, and then everything starts to feel important. So we get flooded with information, and it might be very hard for an individual experiencing psychosis to filter out kind of what's important in their environment, and they might feel very overwhelmed by sensory experiences. So again, this is keeping in mind if you're trying to look for these signs in a client or a loved one, you're looking for new symptoms, not someone who's maybe experienced kind of autism spectrum or sensory difficulties throughout their entire life. So additional symptoms. I keep finding kind of significance in things like I keep seeing blue cars, and I wonder if that's a sign I should pay attention to. I think about it a lot, right? So kind of picking up on things in the environment that we weren't normally paying attention to and attributing a lot of meaning to it. Wondering about kind of suspiciousness, or every time I hear my classmates laughing in the hall, I'm pretty certain it's about me. And so here, particularly when you're trying to differentiate, is someone experiencing some early warning signs or clinical high risk of psychosis? This one can be a tricky differential sometimes between like social anxiety, but typically a way to differentiate that is in social anxiety, the thoughts are more about like self-evaluation, kind of self-consciousness and judgment, whereas suspiciousness and kind of more paranoid psychotic flavor would be about like, I kind of feel like people might be out to get me with some type of malintent as opposed to just kind of judging me. So a bit more kind of persecutory in the nature. Other potential symptoms, sometimes I feel like my thoughts are being broadcast out loud for everyone to hear, right? So we would call this experience thought broadcasting, and it's a common experience in psychosis. And it might, in this case, so that's why I don't want to leave my house. Right? So people, that was that kind of secondary negative symptom that I was talking about. They might be experiencing a positive symptom such as thought broadcasting or auditory hallucinations or suspiciousness. And then as a result, what you see as a parent or a clinician is someone retreating and changing their typical behavior. And if you are able to probe more or get a little bit more info, you might find out that it's because they feel like this experience is going on for them. That's very distressing. Folks might have what we call ideas of reference. Dr. Sykes, I feel like Eminem is sending me coded messages through his songs. And you know what? It's because I'm famous too. So there we've got folks kind of feeling like there's messages out in the environment that are directly for them, and there may even be some associated grandiosity with that. Other experiences, I can actually control other people's emotions with my thoughts. It's a special gift. So we look for kind of the belief that special gifts or powers. An example of suspiciousness, I feel like my family is tracking my every move and thought. Probe a little more, the individual might say, and they must have put a chip in my head while I was sleeping. And lastly, perceptual disturbances. They tell me that I'm no good and that I should hurt myself. So not all perceptual disturbances or auditory hallucinations are command in nature. However, some are. So now that we've looked at a little bit of what these symptoms might look like on a different spectrum, how should clinicians be able to kind of assess these, or what are some strategies? The gold standard for detecting clinical high risk for psychosis, and that we also use in the STEP Learning Collaborative to date the onset of full psychosis, is the structured interview for psychosis risk syndromes, the SIPS. It's about an hour and a half long structured assessment that requires a trained rater. You can receive some trainings at the Prime Clinic, but something that's more accessible to community clinicians would be training in the mini SIPS, which is a 30-minute online module that will kind of help you learn how to detect clinical high risk states. And again, that's not the focus of what we're talking about here, but it's relevant because it really teaches you how to kind of ask the questions about experiences of psychosis, and it can help you connect with a client about whether they're might be experiencing something that's in the prodromal range or in the more full symptoms of psychosis, frank psychosis range. There's also screening tools, although we don't have a perfect screening tool. There's the Prime Screen, the PQB. There's a prodromal questionnaire that's adapted for children. I know some folks in this audience are working with the Prime Clinic on doing a universal screener. I think BH Care, Bridges, Clifford Beers, and other folks are probably well acquainted with the use of the Prime Screen. So those are just so you can have some go-tos if you want a structured assessment or want to know more. But really, I think what's most helpful is some strategies about how to talk to and probe about experiences of psychosis. It really depends. It might be very obvious that someone's experiencing psychosis, or it might be more subtle. But I encourage, clinicians and even family members, to ask when they're talking to young people about psychosis. It's really important to try to remain calm and curious. Okay, above all, someone experiencing psychosis might already have a little sense that like something is off, or maybe they feel some of that stigma, I shouldn't talk about this, or I'm not sure if I can trust people. And so the last thing we want to do is shut someone down or stigmatize them even further. So keeping that tone of kind of curiosity and a calmness is really important. We use kind of what we call soft questions, which I'll give you an example of on the next page and that you can use for your reference. But if someone, say, endorses hearing voices, be curious about it. Tell me more. Tell me what that's like for you. Are they male, female, some other gender? Do you recognize the voice? How are you making sense of this experience? So we're really just trying to engage in a dialogue, helping someone kind of understand that you're not scared of this experience and helping kind of that it's okay to talk about it. And you might even bring in some normalizing psychoeducation, like of, hey, did you know that actually like lots of people hear voices? It's pretty common, 3 in 100 people. And it might even be kind of higher than that. And or that, yeah, I worked with other people who experience this. So you're being curious, you're trying to normalize and helping someone kind of feel comfortable in sharing with you. And so remember that just because someone's endorsing symptoms of psychosis doesn't necessarily mean that they need to go to the hospital right away. I think community clinicians, you all are already working with individuals who have some of these experiences. And I think when I've worked with clinicians, just need to kind of be reminded to have some more kind of confidence in their skills. And of course, consult with other members of your team if you've got concerns about risk or safety, and ultimately do whatever your team and clinic decides is the right step for that individual in that moment. But folks can certainly, function in outpatient clinics and in the world while they're hearing voices or experiencing other symptoms of psychosis. And you can use a lot of your existing skills to kind of support them and talk about that in therapy. Other ways to kind of continue with assessment, it's helpful. We certainly do this through the Learning Collaborative through the STEP clinic rather, to try to get a thorough review of medical records, to try to date and understand when things started, when did changes happen, what other factors might be going on, right? This is thinking back of are there substances involved, or is there an affective component? So medical records, if available, could be really helpful at understanding that. And then of course, if the individual gives permission, collateral supports like family members or other clinicians and hospital records and things that can be really helpful at understanding an individual's course, and to try to get a better sense of what's going on for them. I've kind of alluded to these different phases, kind of your normal limits, your typical phase, the clinical high risk phase, and then what we call conversion, or we could consider it as the first episode of psychosis, kind of psychotic level experiences. And so this is an example question from the SIPS assessment actually, and it's in the suspiciousness and kind of paranoia section. But this is again how I might differentiate the different kind of levels of impact. So the question would be, have you ever found yourself feeling suspicious or mistrustful of other people? A response in the normal, typical limits might be, yeah, I don't completely trust my new roommate, but my mom told me not to trust people right away anyway. So there you've got maybe a common response. Maybe being a little wary of someone right away is really natural in that person's family unit or what they were brought up to believe. Clinical high risk range might look like this. I think my roommate might be poisoning my food in the fridge, so sometimes I throw it out just in case, but I'm probably just being paranoid. So there you've got kind of an unusual belief, although it could certainly be true. They've got this thought that the roommate might be poisoning their food. It impacts their behavior, right? Because sometimes they're actually throwing it out. But then you've got self-generated insight, and you're able to say, yeah, I'm probably just being paranoid, or it's just like my mind playing tricks on me. And so it's not super, super distressing, not impacting their behavior all the time, and you don't have full conviction. Whereas this experience on the severe or frank psychosis level, I'm certain that my roommate is out to get me and is poisoning my food, right? So there you've got full conviction. This feels so true to the individual experiencing this. And in fact, it impacts their behavior so much that they say, sometimes I don't eat for days, right? So then you've got a belief that is causing such significant impairment that it might even be jeopardizing this person's kind of medical, physical safety. Maybe they're so malnourished or things like that. And that might even require a medical hospitalization or someone going to the hospital for grave disability. So you can really see the different kind of levels of symptoms here. And I won't go through all these, but this will just be a reference for some of those, what I was calling kind of softer questions or ways to start asking about some of these symptoms if you don't have a structured assessment. One of my favorite ones is just, do you ever feel like your mind is playing tricks on you? Right? And this can lead to a lot of different answers. A lot of times if someone's experiencing voices or they're unsure what's real or what's not real, they will provide you some responses on this. So I've talked about it throughout the talk. But really to hammer it home, why is intervening early in psychosis important? Research shows that there are clinical, functional, cognitive benefits to shortening that duration of untreated psychosis. We're able to reduce the social consequences of psychosis onset, as I was talking about, so we can minimize social isolation, unemployment, homelessness, and those risk behaviors. Early identification and intervention can greatly minimize disability and improve lives. And we know that from our work at the STEP clinic and the research that we've done, but we know that we need to reach more people. And so that brings me to talking about the STEP Learning Collaborative and all of the exciting growth that we've had over the past couple of years, and wanted to share with folks just so they're aware of what we're doing across the state of Connecticut. The STEP Learning Collaborative is Connecticut's statewide learning health system for individuals ages 16 to 35 experiencing recent onset schizophrenia spectrum disorders. And the purpose of the Learning Collaborative and its main aim is really for all persons experiencing schizophrenia to live fulfilling lives. And we do this by partnering with agencies across Connecticut. And in this case, we're partnering with the 13 LMHAs, allowing us to have kind of 18 clinical sites across the state, and doing this to deliver a system of care that will provide rapid access and ideally to high quality treatment. Additional activities of the collaborative include workforce development, which is kind of part of what we're doing here today and through the training series, stakeholder outreach, informatics. We're constantly kind of refining the care model to make sure that we're modeling best practices at the STEP clinic and trying to disseminate that to community providers and clinics within our network. And we also hope to work on building sustainable care models. The Learning Collaborative adopts a population health approach. And so by that, we're trying to serve all individuals, regardless of insurance status and various statuses with first episode psychosis. The population health-based approach is regularly measuring outcomes, striving for international standards, and addressing access and quality disparities. And so the collaborative is a public academic collaboration between the Department of Mental Health and Addiction Services, so DMIS, the Department of Children and Families, and then Yale's STEP program. And we're located at Connecticut Mental Health Center. Bit of the background on the collaborative, but again, to focus on what our latest as of February 1st focus is really on improving access and shortening delays to care through the development of this statewide network. So as you can see here, and as I mentioned, STEP through the support of DMIS and DCF has been able to partner with the 13 LMHAs. And so we now have a network of providers who are open and willing to receiving referrals for individuals experiencing first episode psychosis in our state. So we have launched a centralized referral number. So I encourage you all, if you don't have this already, to write it down, keep it handy, whether you're a provider or a family member, a community member. You can call this number. You just kind of give a little bit of information about whether you're calling about yourself or an individual that you feel might have psychosis. Share with us the town that they're located in, and one of our team of 5 early detection and assessment coordinators will get back to them within a business day, if not sooner, to screen for psychosis. And if the person's eligible, we will rapidly try to connect them to care in the designated site that serves that person's area of residence. And we're working with agencies and providers at all of these clinics to really work on supporting engagement into care, as we know that folks experiencing early psychosis might struggle to get into care. They might not be very interested in receiving care right away. So we're really working on engagement and shortening that delay to care, ultimately shortening the duration of untreated psychosis. As I had talked about, that can have such profound kind of impact on long-term outcomes for individuals with schizophrenia. That is what the Learning Collaborative is up to. If you haven't heard of MindMap, that is the associated statewide early detection campaign that utilizes social media, mass media messaging, or professional kind of detailing of referral sources. So making hospitals or local referral sources and folks in this room right here aware of the referral number and the ability to access care. So it's really a kind of public awareness and early detection campaign that we've just launched statewide that will help us hopefully find the individuals who are in need of this care and direct them to the referral number and then get them access as soon as possible. And I'm sure there's lots of people in the audience who are very intimately involved in this initiative. We've made great partners and point people and early psychosis champions at each of the LMHAs. And we're going to continue to work with them over the next couple of years to keep improving access and hopefully also improve care quality. Lastly, some concrete offerings of the Learning Collaborative, in addition to that centralized referral number where we're facilitating rapid access to care, offerings for behavioral health providers. Obviously, many of you're all already here, but this is part of the STEP Learning Collaborative training series. So I think currently we have about 10 or 11 offerings that are scheduled, and we might be adding some more, but you can sign up. They're all going to be the first Thursday of the month, 12 to 1, and they really kind of build on each other. And those are aimed at frontline clinicians to try to develop some kind of practical skills to support young people with early psychosis. The STEP consultation line, if you click this link or go to our website, and I'll make sure these slides are available, is a provider to provider consultation line. It's completely free. It's available to any provider in Connecticut looking for kind of expert guidance on supporting someone they might be treating with psychosis. So it's a very, very easy online form to fill out, no PHI, just kind of your name, your contact number, and like vaguely what your question's about. And a member of our consultation team will get back to you as soon as possible to provide kind of expert consultation on your case. This is also available to like leadership and administrative folks who might be looking to get guidance on if they want to update their care model in any way or update some of their offerings and are looking for that type of support as well. We also offer kind of that systems level or agency level consultation. There's a variety of virtual resources online. This recording will be placed up there. And then we also offer various resources for community and family members. We'll have an upcoming series of family and community directed workshops, but it will also be great for clinicians who are working with families to come to those offerings to really learn about some of the strategies that we find are really helpful for supporting a family member who is caring for a young person with psychosis. And that is all I have for today. So I guess my ask of you is if you want to try to amplify and keep up to date on the Mind Map campaign, please follow us on social media, particularly on Facebook or Instagram. Just search Mind Map CT and you'll be able to kind of follow us. The more that people like and interact with the post, it really boosts the impact of the campaign, and it'll help us reach more people and make more folks aware of this resource. And if you have any questions, you can email us at steplc@yale.edu. And for more information, please check out both of our websites. Thank you.